Hi, I'm Nikki Shore-Maxon, and I'm presenting a culture assessment for Nursing 360. I'm an American citizen who had the pleasure of interviewing a woman who identifies as Canadian, as First Nation or Indigenous, and as a nurse. The objectives of the assessment are to get an overview of Canadian bioculture with an emphasis on First Nation people's culture, to understand how Canadian healthcare is run, to understand why Canadian healthcare can sometimes be very slow, to understand why remote areas have poor health outcomes and what those health outcomes are, how Canadian healthcare impacts the workforce, and to understand the nursing implications of symptom management and diabetes within the Canadian healthcare framework. The client I was lucky enough to interview is a 32-year-old First Nations Canadian. I'll call her HU from here on out. She was born in a small remote town in northern Canada called the Pas. At age 4, her family moved to Winnipeg, a much larger and urban area in Manitoba. She currently lives there now and works as a nurse at a diabetes clinic. HU describes Canada as widely accepting and proud of their immigrant status. In her Manitoba area, she quickly rattles off several ethnicities that she comes into contact with regularly. There are pockets of Congolese, Filipino, Laotian, Jewish, Muslim, indigenous or First Nation, and many different cultures. HU describes herself as half indigenous and half Caucasian, but she strongly identifies with her First Nation background. As she quotes, "We are the group of people that Americans refer to as Indian." Her identification as First Nations drives her passion about health. It's the reason why she became a nurse. Her cultural nature is traditionally Western, but she does hold strongly to her First Nation ties. This presentation, again, will touch on both First Nation culture and broader healthcare culture in Canada. Through this presentation, we'll journey with HU as she describes her experiences with healthcare in Winnipeg, Manitoba, Canada, and broader Canada, and touches on what healthcare is like for Indigenous people in remote northern areas and in urban areas. When asked about the Canadian concept for time, HU laughs and says, "Show up on time for your appointment." The clinic where she works is busy, and she says a big stressor is people who show up late for their appointments. It puts the already packed schedule behind. According to HU, the Canadian healthcare system is a single-payer system where the government subsidizes and provides healthcare through regional health authorities, which are publicly run systems of hospital, doctor's offices, clinics, etc. Decisions are made in a macro sense, meaning that decisions pass through the regional health authorities, which are often run by bureaucrats and not necessarily medical professionals. She says this is challenging and frustrating to providers, and it slows the system down. Because there are no privately owned or run healthcare organizations in Canada, healthcare times and waits for treatment can be very slow and lead to poor outcomes. She claims that it once took her 2 weeks to see a general practitioner for strep throat. In fact, one article I read reported that 2 First Nation children had actually died from strep throat because they couldn't get access to care and penicillin. Her cousin with colon cancer took 5 months to get a diagnosis, and she had a friend who had to wait 10 months for knee surgery and was told to stay off her feet and couldn't work. Also, she says emergency rooms are inundated with non-emergent cases because people know they can get in there quicker than their general practitioner. She does say, however, we excel at our cancer care system and prenatal care system. Resources are plentiful. Both are very political topics, so the money is always there. The First Nations population could take great advantage of prenatal care, but there's such mistrust toward the healthcare system and government that the women often won't seek prenatal care. We'll touch more on that later. First Nations people have a strong history of mistrust with the government and the healthcare system, which was seeded centuries ago. Poor nutrition leads to chronic issues such as heart disease and diabetes, crowded living situations, which encourages the spread of infectious diseases such as tuberculosis, a high rate of early pregnancy combined with the mistrust of the healthcare system, which leads to poor maternal care, and there's a prevalence of substance abuse violence, especially against women. HU views communication and time in a traditionally Western sense. She did note, however, that she's sensitive to terminology, as many Indigenous or First Nations people prefer to be addressed in many different terms. Some are offended by the term Aboriginal, and some are offended by First Nation, as there are several different bands. She sticks with indigenous or First Nation. HU identifies herself as spiritual but not religious. Most Canadians identify as Christian. First Nations often follow a hybrid of their ancestral belief system combined with Christianity. Reports show that 90% of Canada is Christian. Remote and northern areas in Manitoba, like the Pas where HU was born, are nutritionally very expensive. Supply chains don't often travel to the far northern distances to deliver milk, produce, and other staples. HU remembers seeing an $11 loaf of bread in a grocery store the last time she visited this year. Lack of choices in education lead to a lot of poor food choices and conditions and a high prevalence of diabetes. She has personally witnessed a baby drinking 7-Up instead of milk in the surrounding areas. She does believe Winnipeg to be very health conscious. Though her Winnipeg area adopts a traditionally Western view of aging, she believes that the great variety of cultures in Manitoba will eventually influence views on death and aging. She is worried that Canada is not prepared for rapidly aging population as nursing homes are at capacity. Alan White's CBC article states that the number of nursing home beds needed in one Canadian area will grow from 4,428 in 2015 to 10,778 in 2036. The older First Nations generation prefers a holistic approach to aging and not a focus on particular disease as an overall description of their health. The Western culture to which HU prescribes is traditional. Her community mourns death by funerals, and the bodies are often buried in coffins or cremated. Some of her elder Inuit relatives desire to be buried where they were born. She says they tell her that this is a sign of respect to their creation. One big topic in Canada is physician-assisted suicide, which lawmakers approved in June of this year, 2016. HU believes that most Canadians support the measure. Conversation typically revolves around policy and how to do it. The law has inclusions such as you must be Canadian or a permanent resident to prevent suicide tourism, must be 18 years age or older, mentally competent, have a serious or incurable condition, and have intolerable suffering. As far as high-risk behaviors go, HU jokes that the cold weather makes people lazy and drunk. Statistics do show a high prevalence of cigarette smoking, drinking alcohol, poor eating habits, and sedentary lifestyle that lead to many of the chronic conditions listed under the bioculture ecology section. Of note, there is a higher risk of teenage pregnancies and violence against First Nation women. Pregnancy and child-rearing practices in First Nation women often lead to high infant young child mortality, high maternal morbidity and mortality rate, because many of the other mothers are very young, poorly educated, have low income, limited nutritional options, and a lack of trust of the healthcare system, which leads to very little prenatal care. HU says that family roles and organization depends on the pocket of Manitoba at which you're looking. There is dysfunction in a lot of the First Nation households. For HU, it's not uncommon to see 6 to 7 kids from 6 to 7 different fathers in a family. Violence and substance abuse has led to the disintegration of the family union. Women often do not live with a spouse, but live with extended family members. The aging population and lag in healthcare can lead to lost productivity when people can't work because of illness and injury. For instance, when HU's friend needed knee surgery, she couldn't work for 10 months. Stress and health issues often lead to a reactive system instead of proactive. These drive absenteeism and lost productivity. We're going to talk later about the drive to push healthcare towards proactivity and other qualities. The First Nations life expectancy for females is 76 years compared to 82 years in the general population. Males have a life expectancy of 69 years compared to 77 in the general population. Respectively, this is a 5.5 and 8.1 year difference. Type 2 diabetes has a prevalence rate of 17.2% of those living on reserves and a 10.3% prevalence rate for those living off of reserves. They also rank among the highest suicide rates in the world. Those between 10 and 29 years of age are 5 to 6 more times likely to commit suicide. It's believed to be because of the culture clash in expectations and attempts to assimilate, which often lead to loss of identity and low self-esteem. Of note, Missing peoples and murders are another problem among First Nation peoples. In the last 30 years, 1,200 women and 1,750 men are missing or were murdered. As mentioned before, one of HU's biggest complaints about the Canadian healthcare system is the wait time for certain conditions. The information listed in this area is from the Wait Time Alliance and shows what they deem as acceptable wait times for conditions, the above being chronic pain. They also evaluate cancer, cardiac, abdominal, and other issues. Because it can take a while to address the pain, patients must understand symptom management. They must understand how to use alternative techniques to manage pain if they cannot get into a clinic to get prescriptions. HU pointed me to a Toronto-based initiative that wants to push the Canadian healthcare system to a more proactive, preventative approach. HU supports this, especially the decentralization of healthcare. She believes having more decentralized, specialized, and focused facilities will help address patient conditions earlier and in a timely manner. She believes this will improve overall population health, improve economic impact, and lead to better prognosis and disease outcome, and ultimately increase patient satisfaction. HU sees a lot of patients from remote areas in the diabetes clinic where she works. Many are so remote that ambulance services do not reach them, and some patients are flown in for non-emergent medical treatments. By the time many get to her, their complications are exacerbated. Many foot problems. In fact, the average is 3-foot complication per diabetic person. She focuses on education around managing complications and trying to live well. She's frustrated with the food choices and acknowledges that there aren't many options available. There also aren't many treatment options available, and wound care is a challenge for many of these patients. Access to many lifestyle changes seem to be a barrier in remote northern areas of Canada when it comes to health. This is exhibited yet again in another article that revolves around cardiovascular health in northern Ontario, Canada. It's a cross-sectional qualitative study using an ethnographic approach and photographs from participants. Research focused on the barriers and supports to cardiovascular health and related lifestyle changes in northern Ontario, Canada. 39 participants were recruited, 12 were analyzed for the study, and they found that barriers to cardiovascular lifestyle include access to healthy foods, access to exercise, access to roads, especially in bad weather, access to healthcare services, access to professionals, and access to sufficient finances. Clearly, remote areas of Canada, specifically the northern areas, experience barriers to healthy lifestyle choices. This significantly affects the indigenous populations that comprise those areas, leading to higher rates of chronic diseases and lower life expectancy rates. As mentioned earlier, Canada is a single-payer healthcare system where the government subsidizes and provides healthcare through regional healthcare authorities. These are publicly run systems of hospitals, doctors' offices, clinics, etc., where every decision is made in a macro sense. It can oftentimes slow down the system, though the citizens don't have to worry much about how to pay for their healthcare. However, the government can cut off money to those who are technically nonprofits. Decisions are often challenged by bureaucrats, and providers get very frustrated. HU says that it's hard to move away from the single-payer system because it's so ingrained in the Canadian culture. She said it gets to be a very emotional conversation, and she likens it to Americans' view on gun control. That, too, is a very emotionally driven subject, and she said it's oftentimes hard to have a mature conversation around healthcare because of the emotions running so high. The Canadian healthcare system provides a fairly financially worry-free, but longer wait time for diagnosis and treatments for the citizens. The most affected are those in remote northern areas, especially the indigenous folk. Their limited access to education, income, healthy food choices, exercise, medical providers, and even roads is problematic. Diabetes and diabetic complications are difficult to manage, as are most other conditions. HU focuses on symptom management with her patients and herself when she gets ill, and says that the push to a more proactive system with emphasis on preventative health will help.